is going to be identified by presentation. Frank hematemesis, coffee ground emesis, and bloody diarrhea. For all the others, it can be either upper or lower. What are the causes of frank hematemesis? Well, certainly in the newborn, swallowed maternal blood. And of course, we know how we're going to differentiate maternal from baby blood, and we'll talk about that. Esophagitis. You can have a pill ulceration. What pill esophagitis? What's the most common scenario for pill esophagitis?
Tetracyclines.
Excuse me?
Tetracyclines, doxycycline.
Tetracycline, usually an adolescent who's being treated for acne, and they take their medication at night with insufficient amounts of water.
I literally saw that scenario in presentation in residency once.
Yeah, my son had it once. So
there's also usually pain from the ulcer.
Yeah, well, he was taking tetracycline. He took it at night. He developed mid-sternal pain. I knew exactly what it was, and I treated him right off the bat. How did I treat him?
Discontinued the drug.
Well, yeah, I'd stop, and what did I give him? What medication did I give him?
Sucralfate?
I gave him sucralfate. Absolutely. There you go. Mallory-Weiss tear. We'll talk a lot about varices because that's going to be your most important differential in the ED. Portal gastropathy, hemorrhagic gastropathy, and peptic ulcer. So all of these will give you frank hematemesis. In terms of rare causes, we're talking about malignancy, duplications. Patients with HSP can present with hematemesis, although most commonly it's lower GI bleeding. Same for hereditary hemorrhagic telangiectasia. And then patients with hemangiomas, generally when they have multiple GI hemangiomas, they'll often have cutaneous hemangiomas as well as a tip-off. So this is a gastric hemangioma that appears here. I doubt that you'll ever see one of these. When we see AVMs, what's the most common site for AVMs in children and adolescents? Right at the hepatic flexure. That's going to be your most common site for an AVM. Coffee ground emesis, again, these are patients who are not actively bleeding, but they can have all the same kinds of diagnosis that the frank bleeder can have. And they're shown here. Of course, you've all seen this. This is probably the most common pathologic finding you see on endoscopy. I guess maybe it's either this or EOE. But here's the
nodular antrum, so H. pylori.
Yeah, this is H. pylori.
Right.
And again, H. pylori can do this. And if you see ulcers in H. pylori, the ulcers most commonly occur in the duodenum. Again, patients with H. pylori-induced duodenal ulcers have what characteristic in terms of acid secretion? They're hypersecretors. Remember, they're hypersecretors. If you remember the H. pylori lectures, those patients who may be achlorhydric or have low levels of secretion or more acid secretion are more likely to have involvement of the fundus and body, and those are the patients who are at risk for developing GI gastric cancer. For the hypersecretors, they develop duodenal ulcers.
Where is the infection in that group? Dr. Schwarz gave you already 2 hints where it isn't. Antrum.
It's in the antrum.
And the reason why? it attacks the D cells. You have to read about that and let us know.
And here's the Menetrier's disease. If you see Menetrier's disease, what infection do you think of? So these are all board questions. Menetrier's commonly associated with cytomegalovirus infection. So bright red blood without diarrhea. Again, the most common thing that we would see would be an anal fissure and or other traumatic injury. And what is the characteristic of the blood in a child who has an anal fissure?
And that it's on the surface of the stool?
It's on the surface of the stool, all right? And it's generally associated with some history of pain on defecation. Proctitis, of course, in the 2 to 5 year group, juvenile polyp. Again, lymphonodular hyperplasia, a common cause, generally caused in a bimodal distribution. One would be in the toddler, 3 to 5 years of age, and again in the pre-adolescent, when the immune system gets revved up. Lymphonodular hyperplasia is a common problem, and it is normal in most patients. It can be an indicator of underlying immune problems, which we'll talk about when I give you the lecture on gastrointestinal manifestations of immune disorders. But most commonly, lymphonodular hyperplasia is a normal response to an active immune system. Patients with a solitary rectal ulcer, colonocomangiomas, gastric heterotopia, hemorrhoids, which we rarely see. If you see a hemorrhoid in a child, what do you think of?
I assume you're not going for just really, really severe constipation.
No, you're not going to see hemorrhoids, and you think of inflammatory bowel disease until proven otherwise. All right. And then cow's milk protein intolerance or cow's milk protein allergy, with or without diarrhea.
Can we do a diversion for a couple moments to see your thoughts? We have a 11-month-old who had radiographic and then surgically proven intussusception. The child had no Meckel's. The child is 11 months old, as I said, has had no previous enteric infections, does not go to daycare, and lives at home, and nobody in the house has had any infections of note. So the question for me is, how did she wind up with a lymphonodular hyperplasia as the starting point for her intussusception?
Does she have lymphonodular hyperplasia?
I've not yet spoken to Dr. Velchek, but one would assume, that's always a little dangerous, that if that's the lead point for a intussusception that went up to the transverse colon, that probably was the cause.
It's possible, but the child may not have lymphonodular hyperplasia. Most patients who get intussusception do not have lymphonodular hyperplasia, and most patients who have intussusception do not have an identified lead point. So it could just be an isolated lymphoid nodule, which occurs normally. So you're probably dealing with you're not going to find the lead point. When you don't have a lead point, an identified lead point, the recurrence rate has been reported to be as high as 20%. So it's something to watch out for. But I don't think you're going to find a clear lead point. Of course, here we go, bloody diarrhea. Again, it's a laundry list, and we'll go over later on how to differentiate according to age and type of presentation, which will be very important. Just to remember, this list is really not all that important because what you really need to do is to be able to identify what the circumstances surrounding the presentation are going to be for each of these diagnoses. Now, this is a common one that always appears on the boards. That's the type of Crohn's disease in glycogen storage disease type 1b, which you'd all know about because it's treated much differently than standard Crohn's disease. How? Well, this is the group that's going to get GM-CSF as treatment. And that's another board favorite.
We saw that at Litch one day.
Yep, we did. Painless melena, again, ulcer disease can be painless or with pain. Duplications, Meckel's, if it's bleeding slow enough, can present with melena. And anything that involves either a duplication or an AVM.
Would polyps present with melena, painless bleeding, or will all?
It depends where the polyp is. If the typical juvenile polyp is not going to present with melena, but if you have a small bowel polyp, which can occur in any one of the number of syndromic polyposis syndromes that we've gone over, where the polyp can be gastric, duodenal, jejunal, or ileal, yes, you could potentially have melena.
Okay.
This is a blue rubber bleb nevus syndrome. This is a very difficult problem to manage, which almost always requires, for curative purposes, some sort of surgical resection. Melena with pain, again, the list is shorter, but again, most melena with pain is going to be upper GI tract ulcerative disease. And now a cold heme positive stool without diarrhea. Again, all of these things can present in any one of a number of ways, and it's all going to be dependent upon not only the location, but the severity of bleeding. So here's, NSAID enteropathy, of course. It's one of the reasons why, if you have a patient in whom you're concerned with evaluating them for bleeding, you make sure that they're not on NSAIDs. If they're on NSAIDs, then a high percentage of individuals on NSAIDs are going to have some occult GI bleeding. In the immunocompromised host, PTLD, we talked a little bit about this when I gave the transplant lecture, but again, this is PTLD and in the stomach. Infections, again, these are the unusual infections which you have to be aware of. Again, esophageal infections, generally you have an immunocompromised host, and they're shown here. Under normal circumstances, none of these organisms should really cause you to have that severe a problem that you're going to have bleeding. But again, you should be aware of the relationship between each of these organs and the associated infections that can cause bleeding. Unique causes in post-op patients, particularly our patients who undergo resection for inflammatory bowel disease, you have to worry about stomal and anastomotic varices, anastomotic ulcers. Dr. Rabinowitz can tell you about our famous patient. I forget her name, Simon, who had gastroschisis.
I don't remember her name, but she refused to have
infliximab.
Well, not only that, but she needed to have more aggressive interaction on her ulcers because she was getting transfused 2 or 3 times a month at her worst point.
Yeah. And this was all anastomotic ulcer. She had gastroschisis. She did not have inflammatory bowel disease. And the etiopathogenesis of these anastomotic ulcers is really unclear. Syndromes, all right? Diffuse vasculitides, HSP, HUS. Know how to differentiate HSP from HUS, all right? Keep in mind that HSP, you may have symptoms, but you're not going to have the laboratory abnormalities that you have in HUS, particularly evidence of renal dysfunction, thrombocytopenia, and these patients, HSP patients, generally do not present with anemia, but patients with HUS do because they have a hemolytic anemia. So again, be very mindful, and you should read up on how you differentiate HSP from HUS. The others are shown here. You should be aware of them and know how to evaluate them. But again, of all of this list, if you're going to consider what's going to be on the boards in the future, the HSP-HUS differentiation becomes critically important. Now, when are you going to get called to the ED? You're likely going to get called to the ED because of significant upper GI bleeding. Again, varices being the most common cause. The others are shown here. Rarely do we have children who have massive lower GI bleeding, and when we do, the most likely diagnosis, of course, is going to be a Meckel diverticulum. And again, that's going to be massive bleeding in a child who otherwise looks well but anemic. Here's a picture of esophageal and gastric varices. We'll have more to say about this in a few slides because we'll get into the management of these problems. So now that you know the differential diagnosis, and again, all of these categories that I reviewed for you, I went through them very quickly because these are things you have to be able to read about. And the best way to do it is in relationship to a patient where you can go through in your own mind what the likely differential is going to be. So first of all, when you are called about a patient with bleeding, you want to inspect the emesis. If it's upper GI bleeding, you want to use a gastrocult. Remember, gastrocult is different from hemocult because the paper that it's analyzed on is corrected for pH. You do not want to use something like a hematest, which is an orthotolidine-based test, and you'll give you a high false positive rate. You know, in the old days, Dr. Rabinowitz and I used to have this constant argument with the ED about passing an NG tube. To me, it is still the most important methodology we have to assess the severity of upper GI bleeding. If you're dealing with a newborn, you do an app test. Remember that fetal hemoglobin resists alkali, and so it can differentiate between swallowed maternal blood and the infant's blood. And then, of course, do a stool guaiac. Now, what the heck is guaiac? Guaiac is actually a plant. It's the guaiacum plant, which produces a colorless compound that turns blue in contact with substances that have peroxidase activity, such as hemoglobin. But keep in mind that red meat and certain fruits and vegetables also have peroxidase activity. They're shown here, and they can give you a false positive, as can oral iron preparations. False negatives, if the bleeding is slow enough and it's in the colon long enough, heme can be degraded to porphyrin by stool bacteria, and that can give you a false negative. So again, this becomes important only when you can visually identify the blood.
Does myoglobin have peroxidase activity too? I forget if myoglobin was one of the things that...
Yes, it does.
Okay, thanks.
All right, pitfalls in diagnosis. Exogenous blood, maternal, epistaxis, medical child abuse, where it's It's not really the child's blood, or something else is going on. Menarche, of course. Pseudobloods, meds in red syrup, red Kool-Aid, anything that's red can give you bleeding. And in the old days, we used to get the red diaper syndrome question, which is Serratia marcescens, that causes urine to turn red. Black stools, iron preparations, Pepto-Bismol, of course, spinach, anything that's very high in iron content or bismuth content is going to give you a black stool, and then false positive results that we already discussed. So, as I mentioned earlier, you want to be able to identify by the age and by the appearance. So in the ill-appearing infant and toddler, they're the diagnoses. In the ill-appearing 2 to 5-year-old, varices, gastritis, stress ulcer.
Pediatrics,
This is upper GI bleeding only. Can somebody mute themselves?
I'm in the middle of a conference. Who is this?
Can we mute, please? I've got a lot of
718
background noise.
718-2704.
Thanks. Of course, greater than 5 years of age, varices start to become very important. That's the ill-appearing. Now, the well-appearing can some of the same diagnoses, okay? And for milder bleeding, it's shown here. So this is just a way for you to be able to develop for yourself a differential diagnosis based on the age to the left and across the top, whether the child is ill-appearing or well-appearing, whether the bleeding is severe or milder. The same is true for lower GI bleeding by age and appearance. Again, under 2 years of age, again, we think of intussusception. We also think of Meckel diverticulum, although it's rare, less than 2. Usually that's the 2 to 5 year age group. Of course, Hirschsprung disease. We've talked about necrotic. We've talked about Hirschsprung's enterocolitis. Of course, an infectious colitis would be the most common cause. And then we go to with severe bleeding under 2 years of age, the child is not going to be well appearing. It'll be only with mild appearing, and then that's when we're dealing with fissures, allergic proctocolitis. And again, the same differential that we talked about earlier. Again, 2 to 5, again, the differential of the HSP and the hemolytic uremic syndrome. So, what do we do? Well, again, when you have a history of GI bleeding and you don't know the cause and you don't know the severity, the NG lavage becomes your most important way to assess the severity of bleeding. If you get bright red blood over to the left, these are patients who you have to prepare for transfusion. You're going to start IV PPI right away. Again, if the patient is cirrhotic, then you're going to give them octreotide plus antibiotics, all right? The ED is going to get an urgent GI consult, and that patient goes to the ICU. Again, coffee grounds, no active bleeding. You're going to start them on a PPI. You're going to get the GI consult. And if cirrhotic, you're going to, again, put them on octreotide, probably also antibiotics. All right, this is true because you're suspecting either hemorrhagic gastropathy or esophageal varices. And in a patient who is cirrhotic, antibiotics are always first-line therapy, as well as, again, octreotide is going to be your fail-safe because of the severity of bleeding. If you get bilious return from an NG lavage, well, then you know it's not upper GI bleeding. So does the patient have hematochezia? Does the patient have a melena? If it's brown stool and with a bilious return, then you're not dealing with anything of urgency. If it's clear, non-bilious, Again, that doesn't rule out an upper GI bleed, but of course makes it likely. So this is a good algorithm to use in the ED for your ED docs to determine the urgency of the GI consult and what the likely severity of diagnosis is going to be. In all cases, however, ultimately, the patient is likely to have an endoscopy. The question is with what level of urgency. So what are the clues in the history? If you have a positive family history of similar presentations, you think of inflammatory bowel disease, polyposis, early colon cancer, not really, peptic ulcer disease, H. pylori, particularly true. You want to know, is this child a child of immigrants, or did the child emigrate from a high prevalence country? You know, we used to joke, because we had a lot of immigrants from Yemen, that if a child was going to be seen in the clinic from Yemen, get the endoscope ready, because the child probably has H. pylori. And that is true for many parts of the developing world. What are the medications? Many medications can cause bleeding. Activity levels in adolescence, gym rats, distance runners, weightlifters have had a lot of in the literature about GI bleeding in distance runners. Again, the cause is unclear. Probably related to some level of bowel ischemia, low level of bowel ischemia, because of the level of activity.
Especially so in female adolescents.
Right.
And oftentimes there's a loss of weight and a element of dysmenorrhea or intermittently amenorrhea are other clues.
Correct. What are preceding symptoms? Vomiting, retching, coughing, anything that could result in some level of bleeding. In the ICU, we think of stress ulcerations, of course. What is the food and water exposures? And again, keep in mind this, what are some of the cues on the rectal examination? Well, if you have a fissure at 12 o'clock or 6 o'clock, that's constipation. A fissure any other place, as the patient is in the supine position, other than 12 o'clock or 6 o'clock, suggests a pathologic fissure, particularly one associated with inflammatory bowel disease. Clues to the physical exam. Pull out the growth chart. Are there skin lesions? Does the patient have organomegaly, especially splenomegaly? Does the patient have other manifestations which suggest liver disease? Is there perianal erythema or other perianal findings? That's common in HUS. Rectal exam. Again, this is one of the situations where a rectal exam is going to be essential. And so there you can do rectal examination externally as well as internally. And if the child is well, is it pseudoblood, cow's milk protein allergy, maternal blood, extraintestinal blood? So again, what is the patient's physical examination like? Do we do physical examinations anymore, Dr. Minowitz? Or if that do we not?
Unfortunately, rare. As we saw today during rounds. Unfortunately, rare.
Yeah, I can tell you horror stories, and so can Dr. Rabinowitz, surrounding the loss of a physical examination as a diagnostic approach. Okay, clues in the CBC: low hemoglobin, normal MCV, acute blood loss; low hemoglobin, low MCV, chronic blood loss; bloody diarrhea, high platelets, infection, IBD; bloody diarrhea, low platelets, abnormal forms, HUS; low platelets, low WBC, hypersplenism; eosinophilia. Again, look at so we can use the blood tests, but you have to learn how to use them. And these are important clues just in the CBC.
This is an excellent slide for the residents.
Yeah.
I definitely ask you to memorize it fully.
What about nuclear medicine techniques? We all know about the Meckel scan. That's the technetium-99 pertechnetate, binds to gastric mucosa, high intensity in the right lower quadrant, which appears simultaneously to the stomach. It could also appear in gastric heterotopia and other duplications. It's 85% sensitive, 95% specific. There are conditions where you get a false positive. And, do you need to pre-treat with an H2 blocker or PPI? Well, it's okay. I'm not sure it's really needed, but it can enhance your study. Then you have the TAG red blood cell scan. I've used this before, but I've never used it successfully. Here again, technetium-99 is labeled to RBCs from the patient. It can identify a very low bleeding rate. And so again, you should look up the tagged RBC scan, although we rarely use this. This is usually in a patient who has occult bleeding that we can't figure out what the source is. So we'll use a tagged RBC scan. Angiography, something we use very rarely. Usually it's the femoral approach, and you cannulate the celiac axis. There is a complication rate in very young children. Again, this is useful if you're looking for AVMs or an occultum angioma, and it can be quite useful. Again, I would do a tagged RBC scan before I would do this, which has a much higher likelihood of having a complicated course. So what are the criteria for upper endoscopy? Significant drop in hemoglobin, second bout of hematemesis, even if the hemoglobin is stable, upper GI bleeding accompanied by pain or tenderness, NG lavage that's not clearing, drop in hemoglobin, but NG lavage negative. You can have duodenal bleeding, and then you get into pylorospasm, and so you don't identify it. It's upper GI, but post-pyloric, and patient with persistent hematemesis. Now, this is emergency endoscopy. Ultimately, all of these patients will likely get scope, but this is emergent or urgent endoscopy. So you want to stabilize the patient hemodynamically. Again, you don't want to endoscope somebody whose platelets are under 50,000. So you want their platelets to be above 50,000. Again, if you're going to endoscope the patient for upper GI bleeding, you better put in an NG tube, a large bore, a Salem sump tube, and lavage with room temperature saline. Again, why do we give IV erythromycin? Anybody?
That's a good question. I don't know. I mean, normally I associate erythromycin with increasing motility.
What is erythromycin?
Well, it's an antibiotic, though.
What is it also?
Motility.
It's a pro-motility agent. It's a macrolide.
It's a pro-motility agent. Ever endoscope somebody whose stomach was full of blood?
For gastric emptying?
That's right. It clears. You want to clear the. If you have a chance, give them a thing of IV erythromycin to clear the blood out of the stomach. It's impossible to treat these patients if all you can see is blood. So, when in the old days we used to argue with the folks, no, I won't go into it. It used to be when we were at King's that they would want us to do the bleeders there, and I said, well, you have to have all of this stuff, and they said, well, maybe not. large upper endoscope. Again, what size endoscope? The minimum diameter is 10 millimeters. All right, because this is because again, particularly if you're going to engage in active therapy, you need a larger bore scope. It also is important because a larger bore scope has a larger suction channel to get rid of blood and secretions. You want to have a bicap, gold probe, and coagulator. Sclerotherapy needles, not that we do sclerotherapy, but we'll talk about when we use a sclerosant solution. A banding device, epinephrine, argon plasma coagulator, endoscopic clips. All of these things should be available to you if you're dealing with a patient in whom you do not know the cause of bleeding. If these are not available to you, then the last thing in the world you want to do is scope somebody, say you need this, and it's not there. Simon, jump in anytime if you want to make a comment.
The only thing to add is that there is these powders that are available, and Dr. Laskaya actually texted me this past week that they have it available at the county. So I was going to go over as soon as Dr. Nathan comes back or I have more time, I will do so.
The powders are probably a good substitute for the argon plasma coagulation for surface bleeding. But we'll go into that. So sclerotherapy, again, in the old days, this is what we used for varices. We don't use it for varices anymore. I'll show you how we do use the sclerosant solutions. Banding, of course, I don't know if you had experience. Have any of you had experience doing variceal banding?
Not on a real person. We only have done it at the demonstrator across the street.
Well, Dr. Benowitz and I had the pleasure of doing this on a number of our patients that he can tell you about. And then injection therapy, again, we'll talk about how we use that. We'll talk about thermocoagulation in a bit as well. So, all right, this is varices to the left and varices to the right. All right, this is why you want to clear the blood, because the one on the right, you can't really don't know what's going on. Here, the left, the varices are clearly evident to you. And so for variceal bleeding, banding has supplanted all other forms of therapy. Bleeding is controlled in 90% with a relatively low rebleeding rate and much better than sclerotherapy. And this is the device. You see these individual bands, and there's a string. You can see the string here that comes up, and each time you pull the string, one of the bands gets released. And what happens? Here you go. You use suction. You suck the varix up into the overtube on the scope, and then you release one of the bands, and it strangulates the varix. And you always go distal to proximal, and you were not going to band more than 3 varices at any one session. I've never had a patient who had to have more than one session, at least initially. They may come back for follow-up. Obviously, they're going to come back for follow-up endoscopy. But initially, usually 3 will do it.
Is the reason for that just like not wanting to disturb the collateral circulation so quickly?
Well, it's also, these things can end up obstructing the lumen as well. So you want to go to the most distal ones, and hopefully the more proximal ones, if they're more, will recede of their own accord.
I see.
But here you can see the purplish hue. These are all, you can see the band here.
And does the patient need to be on a liquid diet for a time after this, or?
Yeah, soft. Yes, yeah, for a few days anyway.
The anatomy is that these are from anastomosis, which we all have, that are virtual, and then they become activated because of changes in portal hypertension. And so when you go distal, you're choking off the blood that's going to those that are more proximal. So some of those will just reverse themselves over time without any actual intervention.
So, when this is not variceal bleeding, if it's a visible vessel, a duophylloid lesion, something else, you use the rule of twos. And the rule of twos is that you always use two techniques. So if you have a visible vessel that's bleeding or an ulcer that won't stop bleeding, you're going to use two forms of therapy. Most commonly, injection therapy plus clipping, but there are other techniques as well. Injection therapy of the visible vessel, you don't inject the vessel, you inject the area around the vessel circumferentially. And the most common solution that you use is epinephrine. The sclerosants were typically used for variceal injection, but since it's the rule of twos, you generally use epinephrine, and then you use another technique, and you can use thermocoagulation, and there are various forms. The heater probe, I've never used. Monopolar, I've never used. High rate of perforation. Bipolar is what we use when we do polypectomy. So again, if you do a polypectomy and you have a bleeding stalk, just touching it with the bipolar electrode is often enough to stop the bleeding. The argon plasma coagulator is something that's good for surface bleeding only. I've never used it. I don't know if Dr. Rabinowitz has used it, but it sort of paints the mucosa, and it's only when the bleeding is right on the surface. And then again, a hot biopsy forceps I've not used.
I've used those.
Here's a picture of the argon plasma coagulator. You see this is probably a surface AVM, and here's what happens after the coagulation. So endoscopic clipping, aside from injection for non-variceal bleeding, is going to be the most common modality that you're going to use. It's effective for the visible bleeding vessel, and again, it's used in conjunction with another hemostatic method, most commonly epinephrine injection. Here are your clips. You should all learn how to use them. Again, this is something that Dr. Rabinowitz and I have used. Actually, I've used it more commonly in patients who've had a gastrostomy and the gastrostomy won't close. I've used the clips to close internally the gastrostomy, but it's also quite effective in bleeding patients. And there are the clips in place.
Each of the clips is a little bit different. That's why we have the orientation lecture in the county early in the year, so that their team and our team gets familiar with what it is that we have and how to use it properly.
Yeah, we generally do not use the tri-clip, which is the Wilson Cook. It's most common the Olympus, which is the quick clip. Some of them can be maneuvered, some of them can't, because you have to get them at the right orientation. So you want to be able to use the kind that you can orient 360 degrees. Medical therapy, of course, again, support intravascular volume, replace blood loss, correct the coagulopathy, supplemental oxygen, reduce gastric acid, reduce portal pressure, treat infection. Vasoconstrictors, Again, octreotide being the most common one for variceal bleeding. The others are there for your edification. It's not something we normally would use. Acid reduction, all of these drugs have really been supplanted by continuous IV, a PPI. The most common one that's used, of course, is pantoprazole or Protonix. And we want to titrate. Yeah, people put them on PPIs. You got to measure the gastric pH. You want to make sure the gastric pH is above 5. And that's true also for variceal bleeding as well, because if you have varices, you have a higher likelihood of also having acid reflux, and acid, of course, is not good for the mucosa. So in any of these patients with acute upper GI bleeding, you want to titrate to keep their gastric pH above 5. Finally,
I'm sorry, just to be a little bit more specific, it is absolutely not the concept as you use 1 milligram per kilogram, even BID. You start out with 4 to 8 milligrams, and then you create it where you continuous another 4 to 8. So those numbers change. AGA is good about updating new information, so you'd use what's updated, but just in your mind, realize that you're talking about a high dose to start, a loading dose, if you will, followed by continuous drip, and that continues until you have done your endoscopy, and then you've had 24 hours of stable hematocrit as a suggestive of no further bleeding.
right. And you don't want to cold turkey someone off of these drugs. You want to taper them gradually. So your final slide is the 10 commandments of GI bleeding. Assess hemodynamic stability. Remember, common things are common. Factor in the age, note the color of the blood, use the NG tube, beware of pseudobloods, assess for a change in bowel habit, look for signs of obstruction or perforation, always examine the anus and the rectum, and again, we don't use contrast studies anymore. We use endoscopy. So, question 1, what's the diagnosis? The most likely cause of this child's bleeding is?
So I was a little bit wondering with this one because it said that the vomitus contained bright red blood and clots. It doesn't say that he had it in that he didn't have it at the beginning and then he got it later. So I was thinking maybe it was E as an echo, but otherwise I would have said C.
That's because you didn't read the question.
A, because it's clean,
Why esophageal varices?
because of portal hypertension,
Excuse me?
because it says a spleen tip is palpated
Yeah, he's
2.5.
got splenomegaly.
Right.
He's got varices. All right? Again, there's no information in the stem that isn't significant.
What kind of portal hypertension do you believe he has, by the way? There is a clue
Portal,
right in.
portal hypertension, post-hepatic.
No, why would you say post-hepatic?
Because pre-hepatic.
There you go. Why would you say that's correct? Why did you say that?
Yeah, I didn't realize it's like
His
refrigeration, so it's pre-hepatic.
his liver edge is normal. He's
Right,
10
it's
years
normal.
Because the
old. He
spleen
has
is
no liver
enlarged.
history.
Right. Liver is normal, spleen is enlarged.
Right.
Right.
What, by the way, what creates the portal vein? Going back to anatomy, which has been a theme today.
It's the confluence of
What tooth vessels? Superior mesenteric and splenic. So that's why you can have it where there would be a clot or some residue of an umbilical vein that was cannulated in the NICU, and as a consequence, there's a buildup from the splenic vein causing the portal hypertension, and the same phenomenon causing splenic enlargement without impacting the liver. Of course, it's pre-hepatic, as Marion pointed out.
Okay.
So is that what this kid had? Like, did he have a portal vein thrombosis or something?
Thank
Yes,
you.
he had a portal vein thrombosis.
And what was the etiology? Just infectious from this?
Well, we don't know. It's not in the history. It could be.
Well,
could,
it
could be umbilitis,
a
could be
congenital
cannulation.
anomaly,
could be a congenital anomaly.
or it could be from umbilical vein catheterization. Those two entities are by far and away the explanation in the vast majority of
Okay.
kids.
4-year-old girl presents with rectal bleeding. She was well until this evening when she passed a normal amount of stool with a large amount of blood, red to burgundy in color, no pain, diarrhea or fever, pale and anxious, heart rate 110, respiratory rate 14, BP 90/55, hemoglobin 10, platelets 180, PT 12, INR 1.1. Of the following, you're most likely to order a test to identify which of the following.
Polyps.
What?
I said polyps.
Definitely not.
One word makes that less likely. It's likely, but one word makes it less likely. Actually, two words.
Okay. What is this child's diagnosis? Until proven otherwise.
I sent everybody an article about this. I guess nobody read it.
This is a Meckel
Meckel's,
diverticulum,
Meckel's.
and you're identifying heterotopic gastric mucosa. The answer is B. This is a typical board question. All right, guys. I'll see you a week from tomorrow, okay?
What's
Thank
up on,
you.
I'm just, I mean, I'm uncertain. What's up on Wednesday?
Oh, no lecture on Wednesday.
Because,
I'm not available.
oh, you're not available. Okay, so we could maybe do something ourselves then. Okay, all right. That's what I wasn't sure. All right,
guys.
take care.
Thanks a lot.
Thank
Bye-bye.
you.
Bye.
Bye.
Thank you. Bye.